for selecting this topic. That is a very rare disease, so we can try to see all the literature about not only the diagnostic algorithm, but also about the treatment. So at first, these are my conflict of interest. So at first, I would like to start with a real clinical case of a 68-year-old patient that arrived in our centers for leukocytosis, splenomegaly, and low-grade fever. And the morphological analysis of the peripheral blood, 57% of eosinophils, and the molecular analysis that was performed immediately was completely negative for not only for BCR-ABL, but also for all the other tyrosine kinase gene fusions, such as PDGF receptor alpha, that is the more common, and that will be the next topic of the next webinar. So the patient performed a bone marrow aspirate that showed dysplastic fusions in the megakaryocytes, marked increase in eosinophilic content, and 2% of blood cells that were confirmed also in the bone marrow biopsy, with also a fibrosis grade 1. So the final diagnosis here was made through the cytogenetics that showed a marker, so a deletion of chromosome 14 in all the analyzed metaphases and also in NGS analysis for the presence of two somatic mutations, ASXL1 and TET2. So unfortunately, without other possible treatment, this patient now is in treatment with hydroxyurea with a good hematological control without splenomegaly. So the webinar of today talk about this part of the international classification in which we diagnose for exclusion the so-called chronic eosinophilic leukemia, not otherwise specified, or in terminology of CEL-NOS, after the exclusion of all the other secondary causes, but also all the other reasons of eosinophilia that were associated with myeloid or lymphoid neoplasm, in particular, the form of patients with eosinophilia and tyrosine kinase gene fusion. So this diagnostic algorithm could be observed in patients with a persistent hypereosinophilia, so means more than 1,500, and after the exclusion of organ involvement and symptoms-based organ involvement, we have to screen for all the other secondary reasons. And then after the exclusion, we have to assess the level of primary myeloid process. So testing FIP1 like 1 PDGF receptor alpha, that is the more common, but then also all the other that we will review in the other webinar, to screen then for aberrant T-cell population by flow cytometry, but bone marrow analysis here, not only for the observation of dysplastic morphology and, if possible, to increase the blast, but also confirming the cytogenetics and molecular aberration could be of help to diagnose CEL-NOS. So CEL-NOS is a myeloproliferative neoplasm that was required persistent peripheral blood hypereosinophilia, but not required the organ involvement, so is variably present in some patients. And we have to exclude all the other form, but the bone marrow findings that now we detailed in particular showed an increased cellularity with dysplasia and the possibility to find some blast, but is, I believe, important to demonstrate clonal cytogenetic abnormality and or somatic mutations. So it's a very rare disease. The incidence in our paper was estimated by Sears as 0.036 per 100,000 person year, but probably could be overestimated here by the presence of hypereosinophilic syndrome. So this disease occurred with a male predominance and the median age of 63 years. And as you know, no organ damage is required. And we have also to exclude the eosinophilia, for example, associated with AML, with inversion of chromosome 16. Not only that, then also associated with CML, MPNs, and MDS. And this is a new paper by SEER analysis reported by Wang, in which, as you see, the annual age-adjusted incidence, and in particular, the increasing incidence after 60 years with a male predominance in particular. So we have to clarify at first, I believe, some terminology, because most of the time in literature there is a very confusing, you see CEL-NOS together with idiopathic hypereosinophilic syndrome, in which indeed the organ damage and the injury is due directly to eosinophil-related cytokines or enzymes. So CEL-NOS could be diagnosed for exclusion only with dysplastic morphology, the presence of blast in the bone marrow, and clonal abnormalities. So the bone marrow is usually hypercellular, with also granulocytic cells, but the most important finding is the dysplasia in megakaryocyte, usually as MDS type, so very small and hypolobated, but also as a possible mixture of MDS and MPN-like. We can also detect this granulopoiesis and this erythropoiesis. Bone marrow biopsy could be also detected fibrosis grade 2 to 3 in 20 to 30% of the patients. But it's very important the abnormalities in the eosinophils, not only in the bone marrow, but also in the peripheral blood, with abnormal granulation, abnormal nuclear lobation, so multilobated or hypolobated with nuclear branching, and a larger markedly left-shifted forms. I believe that is the first sign that we can detect in the peripheral blood, then to allow the physicians to searching for clonal and cytogenetic and molecular analysis. So this is an example, as you see here, with abnormal granulation, abnormal nuclear, such as that is hypolobated, that we can observe in the CEL-NOS. So the recent WHO classification of 2022 revised some criteria and reduced the time of persistent eosinophilia from 6 months to 4 weeks, but required also both aberrant morphology and clonality. So eliminated the increased blast as an alternative to clonality. So alone, the increased blast are no longer considered as an alternative to demonstrate clonality, and suggested also a very rigorous exclusion of all the other non-myeloid malignancies and myeloid neoplasm with eosinophilia. On the other side, as you know, the ICC classification 2022 indeed required more than 10% of eosinophils in the peripheral blood, and suggested also that the presence of increased blast, so means more than 5% in the bone marrow and or more than 2% in the peripheral blood, could be a supportive marrow finding in the absence of this dysplastic marrow morphology. But in the last few years, next generation sequencing allowed to refine the diagnosis of patients initially classified as hypereosinophilic syndrome. One of the first articles by Wang in 2016, NGS was performed in 51 patients with idiopathic form and 17 without diagnosis of CEL-NOS. But the others found that also 28% of the idiopathic form had mutation, and the more frequently mutated were ASXL1, TET2, EZH2, and NOTCH1. Indeed, in the CEL-NOS patients, they also detected some peculiar somatic mutation that we should remember because are pathognomonic of other diseases. For example, CSF3R, that, as you know, is indeed present in 80% of patients with chronic neutrophilic leukemia, but also ASXL1 and ZBP1, that together are pathognomonic of atypical chronic myeloid leukemia. But the ICC remember and suggested that these two could be detected in ACML, but without eosinophilia. That is an important criteria. So as you see, that CEL-NOS with somatic mutations had a median overall survival of only 14 months, but also patients with idiopathic form, so of hypereosinophilic syndrome with mutations, had an overall survival that was completely different as compared to patients without somatic mutations. So probably now this type of patients could be refined as a CEL-NOS. And other articles on this way. So for example, the dysplastic features of eosinophils, as you see in the slide, could be detected in patients with somatic mutation. In this article, 30 patients with an initial diagnosis of hypereosinophilic syndrome harbored at least one mutation, and the most frequently are NOTCH1, SCRIB, STAG2, and SH2BR, followed by ASXL1 and EZH2. So the first sign that we can detect, I believe, also in the peripheral blood of the patients for a possible then NGS analysis. Again, on the NGS, Pardanani in 2016 detected also the somatic mutations, studying 98 patients with Again, hypereosinophilic syndrome after the exclusion of the arrangement, reactive reason, and T-cell receptor. 11% of them harbored pathogenetic mutation, and 15% indeed harbored a variant of uncertain significance. As you see that the frequent mutations involved are TER2, ASXL1, but also P53. So mutations were usually found in older patients with lower eosinophil count. We have to remember that some of these mutations observed in older patients could be also CHIP mutations. And another important paper in 2017, again by Wang and colleagues of MD Anderson, 139 patients. There's a very strong correlation between morphological features and all the other features that could be associated with a CEL-NOS, such as anemia, organomegaly, abnormal platelet count, and abnormal karyotype. And in patients with somatic mutation, there's a shortened overall survival as compared to patients indeed with hypereosinophilic syndrome. A very important paper was indeed published by Nick Cross and colleagues. It's a cooperative paper in which NGS was performed in 1,700 cases referred for eosinophilia. And in 27 of these cases, a STAT5B and 642H mutations was found that usually is associated with lymphoproliferative diseases. So 7 were initially identified as S and 20 as a myeloid neoplasmoid eosinophilia, was completely absent in the T cells, and 9 of 27 cases were also positive for SF3B1. So where the STAT5B mutation exists, the overall survival of patients with CEL-NOS is decreased, is very short, and probably could be detected as a possible marker of this possible rare disease. But is not the only rare mutations associated with a CEL-NOS. Another one was reported in cell patients in which a new variation of JAK2 was observed. This time is an exon 13 indel, in which common 4 amino acid deletion and one variable insertion within the JAK2 domain of JAK2 was observed. That deregulated JAK2. And these patients, this mutation may transform parental BF3 cell to growth factor independence, activating the JAK-STAT pathway. So our patients very peculiar because the criteria for CEL-NOS, but together with polyglobulia, and so are at increased risk of thrombotic events. Important to find JAK2 mutation because ruxolitinib can act in this type of mutation. Another one is a novel JAK1 mutation that was indeed observed by Somali 3 years ago. Is again a deletion insertion that lead to interleukin-3 independent cell growth and JAK-STAT activation. Again, was indeed reported that probably ruxolitinib may abrogate the possible effect of this mutation in these patients. CEL-NOS is a very rare disease, but with a very poor prognosis. So this article with only 10 patients reported by LBIG showed a median overall survival of only 22 months. But the most important factor is that in a median survival of 20 months, half of these patients presented acute transformation. So in all patients, imatinib was ineffective because it was tested, but as you know, without the common tyrosine kinase gene fusions is impossible to cure these patients with this drug. Another series of 17 patients was reported by the Mayo Clinic, and the percentage in their institute is 1.2% because they found 17 patients out of more than 1,000 patients that were referred for eosinophilia. Again, as you see, that the median age is 63 years, that 15 patients had abnormal cytogenetics, not common for this type of disease, but is, as always, as for example, trisomy 8 is in the other myeloid neoplasm. 43% of the patients had ASXL1 mutation, and 3 of them had a leukemic transformation with a median overall survival of only 16 months. So in univariate analysis, considering the very small number of patients analyzed, the prognostic factor associated with a worse overall survival are atypia in the peripheral blood, eosinophils and megakaryocytes, abnormal karyotype, and increased LDH. And for leukemic transformation, again, the dysplastic features of eosinophil in the peripheral blood and bone marrow, but also marked fibrosis, complex karyotype, and lack of response to therapy. The treatment of this rare disease. So I review all the literature, and most of these patients with CEL-NOS are included in the group of hypereosinophilic syndrome. So the mainstay of treatment is steroid therapy. And in a series of 188 patients, 75 of them can achieve the CR or PR with the maximum dose of 40 milligram with 10 milligram as a maintenance. In another series, 30 milligram as the maximum dose with 64% of patients with resolution of eosinophilia. Such as in our patients, the other drug that was tested usually is hydroxyurea that can be used in non-responders patients, and the responses reported ranged between 60 and 70%. The other one that I believe could be an important drug because can act not only on the hematological control, but also as a biological control, in which was reported also cytogenetic remission, was tested also in CEL-NOS refractory to other therapies and can be used, for example, to reduce the dose of steroids, is interferon. So interferon response rate is between 50 and 75%, reported as a monotherapy or in combination, usually suggested with a starting dose of 1 million 3 times a week that gradually escalating to 3 to 4 million of units to control eosinophilia. In some patients, interferon allowed also the remission of organ involvement, in particular cardiac failure and thromboembolic complication. But as you know, as another myeloid neoplasm could be associated with long-term effects, such as fatigue, flu-like symptoms, but also transaminitis, depression, hypothyroidism, and peripheral neuropathy, and was considered safe in pregnancy. So 2 cases of CEL-NOS that were treated with interferon in literature, specifically 1 Italian patient of 21-year-old with leukocytosis peripheral eosinophilia was defined as CEL-NOS because of the marked dysplasia in the bone marrow, but also because of the translocation between the chromosome 1 and 5. So he started interferon at the initial dose of 3 million of units 3 times a week, escalated then to 9 million of units 3 times a week, and after 2 years, these patients reached a complete response, hematological, with a major cytogenetic response that long-lasting. The second case indeed is more complicated, of 26-year-old male with leukocytosis, peripheral eosinophilia, splenomegaly, and translocation between the chromosome 3, 9, and 5. So these patients had also congestive heart failure, was refractory absolutely to steroid and hydroxyurea. Then the situation was also complicated because received chemotherapy as another line of therapy, and finally started interferon at the dose of 1.5 million of units 4 times a week, and achieved marrow peripheral response and also improvement of cardiac situation. So PEG interferon could be also the other possibility, but remember that in literature only this article by MD Anderson was reported, then showing also only 4 hypereosinophilic syndrome, in which only 1 achieved a complete response, but we have no mention of bone marrow findings of clonal aberration in these 4 patients. So we have no information about the possible final diagnosis. So in patients refractory to all these drugs, we can use also chemotherapy. Hematological benefit have been observed with drugs such as vincristine, cyclophosphamide, etoposide, or 2-CDA in combination with cytarabine or cyclosporine. But only selected cases responded to imatinib at the increased dose, usually short-lived response. If we see responses in this type of patients, probably these patients had a cryptic PDGF receptor alpha or beta mutations or other of unknown pathogenetic targets, so could not be defined as CEL-NOS. A recent systematic review of treatment has been also reported, in which only 12 patients with this rare diagnosis was indeed showed, and as you see that the more frequent treatment use are steroid, again, hydroxyurea and interferon alpha. And I revised also the literature about the monoclonal antibodies, and I found only two cases in which they could be defined as CEL-NOS in a series of 11 reported by the MD Anderson, treated with alemtuzumab, so anti-CD22, 52, sorry. So the first one is affected by trisomy 8, achieve an important response and then died of unrelated medical reason, but still in hematological control. The other one indeed could be defined as CEL-NOS because of translocation 5-6 relapsed after a short-lived response and died after not responding to nilotinib and to chemotherapy. And finally, only a single case was reported with a dramatic resolution of eosinophilia within the first 24 hours with reslizumab. So this patient was diagnosed as having a CEL-NOS by the presence of TET2 mutation. But as you know, the TET2 mutation could be also found as a CHIP mutation in patients older. So previously, this patient was treated with steroid and immunosuppressive therapy and then received reslizumab at the dose of 3 milligrams per kilo. All the other studies that reported the results of monoclonal antibodies involving patients with S never reported possible bone marrow findings. So the take-home message is, it's a very rare disease with poor prognosis, more frequently observed in male and older patients. The diagnosis was made after exclusion of all the other, and in particular, only in case of morphological bone marrow dysplasia, increased blood cells, and or clonal abnormalities. NGS analysis allowed to refine the diagnosis in patients initially classified as S, but the suggestion is to perform these analyses only in patients with specific morphological atypia in the peripheral blood and in the bone marrow. And as you see, that is a very orphan and rare disease. So the treatment remains conservative. Unfortunately, we have no specific and selected drugs. Thank you very much for your kind attention.
I'm going to continue talking about clonal HES variants, but this time the clone concerns T cells and no longer eosinophils themselves. And in particular, I'm going to stress the existence of a very particular subset of T cells, which is that of CD3 negative, CD4 positive T cells. So these are the objectives, and just not to lose too much time, I'm going to skip this slide, rapidly show you my potential conflicts of interest, and continue. This is a slide you've already seen about hypereosinophilic syndrome with the definition. I think there's no need to go back into that, but I just wanted to include it in the slide set when you will have access to it. So lymphocytic variant hypereosinophilic syndrome obviously first has to fulfill the condition of having blood hypereosinophilia that is complicated by eosinophil-mediated organ damage and dysfunction. And we've just seen a series of examples and conditions where the eosinophilia is clonal and it's driven by mutations that occur in the eosinophils or their progenitors. What I'm going to talk about today is the situation where there's increased presence of eosinophilic factors, and more specifically interleukin-5, which is the problem, which is driving eosinophil expansion. Just a tiny bit of history before that. There was already, since the very first case descriptions in the series of hypereosinophilic syndrome, a strong suspicion that there were patients who did indeed have an underlying immunoallergic type of disorder that was being driven by T cells. And I just gave you a few citations on this slide to underline this initial suspicion, but it was obviously a purely clinical and empirical constatations that led to this suspicion. At the time, though, and that was pretty interesting, it really shows the bench to bedside kind of movement that leads to advances in understanding human diseases. At the time, there were murine studies going on that had just described the fact that among T cells, helper T cells, there were different types of T cells with different functional properties. And this is really the time in the 1980s when Th1 versus Th2 clones had been derived from circulating T cells from mice. And then this concept was progressively extended to humans until there were clearly human disorders wherein type 2, so Th2 polarized T cells, producing these cytokines, IL-4, IL-5, were really the signature cytokines, were driving eosinophil expansion on one hand and differentiation of IgE secreting plasma cells on the other hand. And it's really in this era when this was around and when, for example, atopic disorders were being linked to this type of Th2 inflammation that my former head of department encountered a patient with a hypereosinophilic syndrome whose clinical presentation and biological findings were strongly suggestive that he may have a Th2 disorder. This had never been described, obviously, at the time in the setting of hypereosinophilic syndrome. So this was a man who was pretty young, as you can see, who had a series of clinical manifestations of his hypereosinophilia, and he had markedly elevated serum IgE levels, exactly as had been described in mice with Th2-driven disease. And so on that very first case, the patient's blood was sent to a lab where a series of T cell examinations were performed, consisting in lymphocyte phenotyping and TCR gene rearrangement analysis. And as you can see here by lymphocyte phenotyping, it was rapidly evident that this patient had a completely abnormal subset of CD4 positive T cells that had lost surface expression of the CD3 antigen. And when looking at these cells, these are ancient methods for looking for clonality, obviously, but when looking whether these cells were monoclonal or polyclonal, what was also rapidly apparent was that the CD3 negative, CD4 positive T cells really had a clonal TCR gene rearrangement pattern. So this was a monoclonal T cell disorder, which was driving hypereosinophilia. And it was driving hypereosinophilia through the production of type 2 cytokines, and more specifically IL-5. And what you can see here is the production of these different type 2 cytokines versus type 1 cytokines, either by the CD3 negative, CD4 positive T cells, which are shown in dark here, versus the patient's control CD4 T cells that were CD3 positive. And you can see that upon in vitro stimulation, the production of IL-4 and IL-5 was extremely elevated, whereas these cells produced practically no signature type 1 cytokines. So these were clonal Th2 cells in the blood of the patient. That was a single case report that was published in the New England Journal of Medicine. And since then, it's clearly a recognized entity. I'm just showing here the citations of the two largest cohorts which have been published to date, one from our center and one from the French eosinophil network. Disease manifestations of this particular subset of patients with hypereosinophilic syndrome. You can see the green bars are the two largest cohorts of lymphocytic variant hypereosinophilic syndrome, whereas the blue bars are derived from two series of patients who had FIP1-like-1 PDGF receptor alpha associated hypereosinophilia. And Professor Breccia will go into that into much more detail during the next webinar for that particular disease variant. But what you can see is that there's some disequilibrium between the clinical manifestations depending on the disease variant. In particular, patients who have lymphoid HES have predominant skin manifestations. They often have some degree of lymph node enlargement, although this is not always clinically apparent. Sometimes it can only be seen by performing a PET scan showing modestly hypermetabolic lymph nodes in a series of different regions. And you can also see here that lots of these patients have muscle and joint problems. Essentially, it's fasciitis and tenosynovitis. And another striking feature is that the cardiac involvement in this particular variant is particularly rare. There are a couple case reports that have been published, but besides that, it's really very uncommon. What are these cutaneous manifestations and this angioedema that I described? These are the types of lesions that you can commonly see, but there are many, many different forms of cutaneous presentations. And here's one patient when she does not have a flare of angioedema versus when she does. And you can see that this can be responsible for weight gain and from anywhere between 5 to 10 kilograms when a patient is flaring. This is typically what would be called Gleick's syndrome or episodic eosinophilia with angioedema, or episodic angioedema, with hypereosinophilia. The abnormal clonal CD3 negative, CD4 positive T cells have clearly been shown to be present in affected tissues together with eosinophils. So what you see here is a cutaneous biopsy, lots of eosinophils, but also clearly lots of lymphocytes. And the French team digested skin biopsies from these patients and lymph nodes to clearly show the presence of these CD3 negative, CD4 positive T cells from 2 patients that can be seen here. Patient 1, patient 2, you can see the same population of CD3 negative, CD4 positive T cells in the skin. And if you look at the TCR gene rearrangement pattern in the skin, it's the same as that is seen in blood. So clearly, these abnormal T cells are infiltrating the tissues, which are clinically affected. Just to be complete on the clinical manifestations of this disease, some patients who have hypereosinophilia of undetermined significance, meaning patients who have apparently unexplained hypereosinophilia, which is persistent but completely devoid of target organ damage. Well, among some of these patients, you will find a very, very small category of patients who actually have lymphoid variant hypereosinophilic syndrome. And it's quite typical, and we have a few cases like this, where patients will remain asymptomatic for many, many years, despite the fact that they have high eosinophil levels in their blood. They do have detectable CD3 negative, CD4 positive T cells, and they remain without symptoms. But the majority of these patients will eventually develop some form of clinical manifestation of disease. Another important thing to underline, I said this is with an indolent lymphoproliferative disorder. Some patients will actually progress to T-cell lymphoma. And this is the example of one of our patients. It was published as a case report, who came into the clinic with a very, very sudden enlargement of a lymph node, as you can see here. She had been extensively worked up for T-cell lymphoma about half a year before this occurred. And she was negative. She had had lots and lots of investigations. But when this lymph node was examined, clearly this was angioimmunoblastic T-cell lymphoma. The markers had changed. For example, you can note the positivity for CD10 here. And looking at combining both the French cohort and ours, so that's not far from 50 patients, the incidence of progression to T-cell lymphoma seems to be roughly 10% after a pretty long delay, as you can see. How do you reach a diagnosis of this disorder? Well, first of all, I'd just like to insist on the fact that the first patient, we were lucky because he had a really, really big abnormal population. And so you do T-cell phenotyping, you can see it immediately. But since then, in our cohort, we have found quite a few patients who have tiny, tiny little subsets, sometimes less than 1%, abnormal CD3 negative, CD4 positive T cells. And so we have developed a specific T-cell flow phenotyping panel to be able to really determine with a high level of reliability that these are the abnormal cells. And they consistently have an overexpression of CD2, CD5 as well. It's not shown here. They are 100% CD45RO, 100% CD495, and they generally have low or negative expression for CD7 and or CD27 on their surface. So this all increases the reliability of the diagnosis. Another test that can be done, which is not done in routine, unfortunately, but that can be really interesting, is measurement of serum levels of the chemokine TARC, which is a type 2 chemokine, also called CCL17. These are our L-HES patients, and you can see striking elevations of these serum levels. And we were actually able to make a ROC curve and determine that the level of 3,000 picograms per milliliter had the highest sensitivity and specificity for L-HES. Although, as you can see here, some patients who have organ-restricted disease, and more specifically who have skin hypereosinophilic symptoms, so really restricted to the skin, also have elevated serum TARC levels. So it's not completely specific. In terms of treatment, well, some of these patients actually do not require treatment because their symptoms are mild and because the trade-off between the side effects of prolonged treatment versus the symptoms is in favor of no treatment. So this is roughly 1/4 of our cohort. But many patients, I mean, as you can see, it's 3/4, actually require prolonged corticosteroid treatment. And unfortunately, it's sometimes pretty high-level treatment, as we will see in the following slides. And many of these patients, because they require high-dose corticosteroids for prolonged periods, often require second-line treatment as well. We will go into those treatments with a bit more detail. This was just to illustrate the level of corticosteroid dependency. And as you can see, more than half of patients require more than 10 milligrams prednisone daily for disease control. This is our cohort, but this was also shown in the NIH cohort, which is also a very, very vast cohort of patients with various HES variants. And you can see here that among patients with L-HES, at least, well, half of the patients needed at least 20 milligrams to be able to be stabilized. So this is once again confirming the high level of corticosteroid dependency. So what second-line agents do we have for these patients? Interferon alpha, already mentioned by the previous speaker, seems to be the most promising agent. This is the French series on the left, our series on the right, and you can see that the level of complete and or partial responses is extremely high in this very difficult to treat patient population with lymphoid variant hypereosinophilic syndrome. As for eosinophil targeting agents, the responses are more mitigated, they're less clear. And this is our series of patients where you can see that although biological responses were not that bad, eosinophil counts did go down in many patients, sometimes only partially. You can see that actually the clinical response can be disappointing. And this is just to illustrate one of our patients who received anti-IL-5 therapy. This was her skin manifestation before treatment. This is what became of her after anti-IL-5 treatment. So she clearly considerably worsened. And this was not because we decreased corticosteroid dosing. She actually had to increase corticosteroid dosing while taking anti-IL-5. And her skin still contained some eosinophils, but also a massive amount of these pathogenic T cells. And I'm not going to go into a great level of detail for want of time here, but I just want to show you that this is the mepolizumab duration of treatment in this patient. You can see that when she was receiving mepolizumab at the dose of 300 milligrams daily, her eosinophil counts were still really, really high, between 1,000 and 2,000 eosinophils per microliter. And she required increase of her mepolizumab dosing to 700 milligrams IV to finally see her eosinophil counts going down. Unfortunately, when we decreased the corticosteroids that we had to increase because of her cutaneous manifestations, you can see that the eosinophil counts went back up. And even more preoccupying was that this high dosing of mepolizumab was accompanied by a massive increase of her clonal CD3 negative, CD4 positive T cells in peripheral blood. So we eventually stopped treatment and started something else that I'm going to describe right afterwards. So this is just kind of to recapitulate what I just said. Perhaps the main advantage with interferon is that it may actually decrease, and even in some cases, one of our patients experienced complete disappearance of the CD3 negative, CD4 positive T cells. So this is really a first choice in terms of second-line agents, but unfortunately in Belgium, it's practically impossible to obtain in this particular indication unless patients pay from their own pockets. Eosinophil targeted therapy, it certainly is worth a try. It sometimes works, especially if you give higher dosing to some patients, they may experience clinical benefit in those conditions. And so just to come back to that patient that I was describing where we eventually had to stop mepolizumab, we tried a series of other things which didn't really work. You can see that she failed anti-IL-4 receptor alpha, she failed hydroxyurea, she failed methotrexate, she failed cyclosporin A. She did have a partial response to interferon alpha. As I said, that's a good choice in patients like this, but she developed alopecia. And because of this alopecia, plus perhaps there were a couple case reports, a small series of 4 patients who had received JAK inhibitors, we tried tofacitinib, and you can see that her eosinophil counts successfully decreased with this treatment. And most importantly, she was able to decrease considerably her background corticosteroid therapy. But as you can see here, unfortunately, her abnormal T cell counts were grossly unchanged throughout treatment with tofacitinib. And this has been confirmed by others. These are the abnormal CD3 negative, CD4 positive T cell counts from a French study showing that their levels do not change with JAK inhibitors. In this study, most patients were receiving ruxolitinib, except for this one in red, it was also tofacitinib. So this is not a miracle drug, but it certainly enables corticosteroid treatment in some patients with hypereosinophilic syndrome of the lymphoid variant, and will certainly have a good impact on blood eosinophil counts in these patients. There is a series of unmet needs in this particular disease variant. We still have more questions than answers. I think we have progressed in treatment and diagnosis, but we still don't understand what the primary molecular event, which is driving expansion of these phenotypically aberrant T cells. We still don't have targeted treatment options really directed against these clonal T cells. We're working on that. We're working on trying to understand what makes these cells survive and what has them activated, but there's still nothing, there's no groundbreaking discoveries that have been made so far. And then clearly there are other L-HES variants that we're not grasping yet. Remember that I showed you those patients who have elevated TARC levels among those who have organ-restricted disease. There's still a lot of work to do in terms of understanding L-HES variants other than patients who have CD3 negative, CD4 positive T cells. And I will end with my take-home messages here. So L-HES is an indolent lymphoproliferative disorder with a potential for malignant transformation. Almost all patients have cutaneous manifestations and or angioedema. So these have to be clues in the clinic. If you have skin, angioedema, fasciitis, and hypereosinophilia, do a thorough T cell phenotyping with the different markers, if possible, that I showed you on one of those slides. This disease is often corticosteroid dependent and with high dosing regimens. That's why we often have to introduce second-line treatment options in these patients. Perhaps the most interesting is interferon alpha, that so far, let's say, because it reduces the aberrant T cell counts, in addition to really acting directly on type 2 inflammation. Mepolizumab is certainly really interesting still because I have several patients who respond relatively well, but they tend to require higher dosing than that which is approved by the FDA and the EMEA. But it's worth giving it a shot because it can really decrease corticosteroid requirements in these patients. JAK inhibitors may be a promising alternative in the future, but it certainly is only suspensive. It's not going to cure patients of their primary T cell disorder. And there have been cases reported of allogeneic stem cell transformation. This is something which should mostly be reserved for patients with malignant transformation because there have been case reports of patients who have been transplanted while they still had their indolent disease, which was not considered malignant, and they have died of the procedure. So that's really very unfortunate. And maybe perhaps in some cases have really severe disease with severe clinical manifestations, refractory to all treatment options. This could be an ultimate treatment option, but it certainly is not ideal. There, and with that, I'd like to thank you for your attention and would be really happy to address any questions you may have on this particular form of hypereosinophilic syndrome.
Thank you very much also to you, Professor Roufosse. So now we have 10 minutes for receiving questions. While you may formulate them in the chat, I would like to advertise next webinar. So we take time for receiving questions. And so I would like also to share with you the news that the next webinar won't be on the 20th of May, but it has been postponed to the 27th of May. By the way, you will receive also via email this notification. So next one will be on the 27th of May. We will have with us Professor Breccia, and we will talk about clonal hypereosinophilic conditions, myeloid lymphoid disorders with eosinophilia and tyrosine kinase fusion genes. Okay, so I see the first question to Professor Roufosse. Did anyone try to find out if there is a clinical OPR biological marker that could anticipate L-HES evolution in T-cell lymphoma?
So far, no. Unfortunately, obviously this is a super rare disease and lymphoma is a super rare complication. So at least clinically, what I can say is generally the cases that are transformed at time of diagnosis of malignant transformation, it's because all of a sudden you have a lymph node which increases massively in size, or a new lymph node which appears on PET FDG scans, which is why I tend to follow my patients with PET FDGs over time. Sometimes it's also the brutal increase in the absolute count of these abnormal cells, and that's why we got so worried when our patient who was receiving mepolizumab had more than doubling of her abnormal cell counts. So that's something which has been reported. And finally, we published this many years ago. Two of our patients, one of whom progressed to lymphoma, had developed karyotype abnormalities. She had a partial 6q deletion, and she had several additional abnormalities, but when there was malignant outgrowth, this 6q deletion was the only one that remained. So clearly, that was what had conferred a selective advantage to one of the subclones among the CD3 negative, CD4 positive T cells. But so far, clearly, there's nothing which allows to predict which patients are eventually going to follow that path. The ones that I have seen, they had very different clinical presentations. One had a very typical Gleick syndrome. Another one had a completely different presentation, which was more with lungs and cutaneous manifestations. So there doesn't seem to be something clinical or biological which predisposes to that particular progression, knowing that it's super rare.
And so, continuing the same question, how often do you perform imaging like CT scan, PET scan in those patients?
Yeah, it's a super important question as well. And to tell you the truth, there are no official recommendations. Kind of depends on the patient. If it's a patient who consistently has some degree of, it's generally very mild hypermetabolism of lymph nodes on PET scans, that's someone that I will scan yearly, looking for a change. Whereas if it's a patient who, after several years of doing a yearly PET scan, I see that there doesn't seem to be, anything that's happening, I will tend to increase the interval, maybe sometimes to 18 months. And then some patients sometimes take time to do their second exam, so it's going to end up being 2 years. I try to avoid it being longer than 2 years.
Thank you. So I move to the next question. Is anti-TRBC1 of any use in these patients diagnostically?
That's a very interesting question, and I will admit that it's a question that we're only just beginning to look into now. I have 2 doctoral students who are really working on that right now. Yes, it seems to be promising. It's very new, as you know. It's something that really, I think really has yet to be shown to be useful in this setting. But it's a very, very interesting question, Shirley.
Thank you. I move to the other question. I have a patient, W-L-H-E-S, who is clinically stable but developed venous thrombosis without any provoking cause, apparently. Could be an indication for therapy? Thank you.
Is this a guest question for Professor Breccia, or is it addressed to both of us?
No,
I didn't understand. I understood
I let you
W-H-E-S.
decide.
Is a patient with lymphocytic variant, Florence.
Okay, sorry, I didn't get that. Okay, well, whether it be lymphocytic variant or I'd say idiopathic, I think definitely, hypereosinophilia can be associated with hypercoagulable state. That's for sure. There's no doubt about that. We have experienced that in our center, and I'm sure Professor Breccia as well. Something can be the only manifestation. It can be the inaugural manifestation. Obviously, it's always the same thing in medicine. It's internal medicine, right? You have to make sure that the patient doesn't have any other factors which are predisposing to having developed this thrombosis. But the added eosinophilia on top of that, even if there is something which kind of predisposes, well, we would tend to want to lower the eosinophil count with treatment. The answer would be a global yes, taking into account, as usual, the risk benefit, the potential other alternative explanation for venous thrombosis, obviously. But just to give an example, one of our patients' inaugural manifestations was a thrombosis in the internal jugular vein with intracranial extension. And the only other thing she had was, I think she had a polymorphism for protein C. Well, this was a patient where it seemed to be really super important to be able to treat her hypereosinophilia, for example.
Thank you. So let's see if we received I guess the last question or not. Yes, there is one comment. Okay, thank you, Professor Roufosse. In fact, I had doubt if it was an indication to treat the patients or not, because there is not any other symptom or organ involvement.
It's considered organ involvement if there's coagulation. You could see it in the heart cavity, you can see it in a vein, you can see it in arteries. It's considered one of the complications of HES. So yes, we would consider that an organ manifestation of disease.
Okay.
So I see no other question, Mariangela. Can I ask to Florence a clarification? Because I see on the presentation of Florence the possible use of ruxolitinib in these patients that, as you know, we use for myelofibrosis patients. So is a specific drug that inhibits JAK1, no? Is an immunosuppressive treatment, and most of these patients may have also possible infection. So do you know if the ruxolitinib, in cases in which lymphocytic variant has been treated, they have also infections about it?
So the only paper I know of is the one that I showed a figure from, where there were 4 patients, one who had received first tofa, but since he didn't respond, received ruxo as well. It's not mentioned. There aren't any details. I have no personal experience. I only have experience with tofa in the patient that I showed you, and in several other patients who have idiopathic hypereosinophilic syndrome. And then there's that very, very first article in Blood by King and colleagues. So, I mean, it's a handful of cases.
Okay,
yeah, unfortunately.
Thank you very much.
But I think there's interest for that, and I think there's a clinical trial that's ongoing, but it's not ongoing for L-HES. It's really ongoing for the more myeloid disease forms.
Okay, thank you.
The idea for these JAK inhibitors in L-HES is that L-HES is clearly a cytokine-driven disease, and the idea is just to get rid of the cytokine signaling. It's not a molecular target.
Okay. Yeah.